No visuals. No visuals.
It'll just help.
No visuals. It's your task to talk to us.
Can we just...
No. What don't you understand about that? No. Talk to us, Asher, or Felix, or Jason. Talk to us. Here we go. You're in the operating room explaining this. You can't pull out visuals. I would want you to have a discussion with us about this paper.
We don't have any piece of paper.
Asher, no.
Okay. All right.
The POISE trial is a randomized control study comprising about 8,000 subjects. It happened in 2002 through 2007. They used metoprolol as their beta blocker, and how they did the study was that they gave metoprolol 100 milligrams 2 to 4 hours before surgery, and the second dose was 12 hours after, which was 200 milligrams, and continued.
First dose was 100, and then it was 200.
200, then continued 30 days post-op.
And there was a huge study that was conducted in 29 countries, excluding United States. It was done in Europe. It was done in Canada, Australia, Asia, everywhere, but excluding the United States. It was published in 2008 in the Lancet journal.
And the primary findings were in contrast to what Jess and Jill's study showed, that there was an increased incidence of stroke, there was a decreased incidence of non-fatal MI, and there was a decreased incidence of, what's the other one?
Is it increase in overall mortality too?
Yeah.
Total mortality?
At 30 days?
After 30 days.
During 30 days.
Yeah, so some of the patients died within the 30 days.
Yeah.
So increased mortality, increased incidence of stroke, but decreased non-fatal MI, incidence of non-fatal MI. So it was quite in contrast with some of what the studies Jill and Jess presented.
And it was, of course, prospective and very, very...
There was a huge sample size. And,
they had it quadruple blinded, so patients, providers, data collectors, and data adjudicators were blinded. Only those who
analyze the data.
Analyzers were not blinded. So that was the highest. And they had very rigorous inclusion and exclusion criteria. They had to have some predisposition factor that would justify the administration of beta blockers. And the other thing, that all the patients were beta blocker naive, they never took beta blockers before. So that was the administration of beta blockers before the surgery was their first encounter with that kind of medication.
They excluded everyone that had a heart rate below 60, those who had a second and third degree AV block.
I would say those who couldn't take PO were given IV.
Yeah, that was the only thing that was kind of vague, that we did not really understand how they made adjustments for patients who could not take post-op oral metoprolol. So they gave IV, but the way they were giving it IV was not quite clear, I would say.
What did you get out of this study? This is a highly cited study. A lot of people talk about the POISE trial. What does POISE stand for? Do you remember?
Preoperative.
Forget.
What had perioperative in it? I think ischemia, beta blocker evaluation, something like that. What did you get out of this?
Well, primarily the risk outweigh the benefits of preoperative beta blocker use.
At least at that dose with that drug, right?
Yeah, that drug and that dose and that time frame of using it.
The other thing, they were not adjusting the dose to the to the patient weight. So they were giving, in our opinion, they were giving too much, huge doses. That's one thing. The other thing, we understood that patients should not start beta blockers too close to the surgery. And the other thing,
I was going to say, I also said, that there needs to be more study on this. It's just because everything's conflicting. There needs to be more prospective studies on this topic.
They did some post hoc analysis of the causes that might have contributed to the mortality due to beta blockers, and they quoted that patients' hemodynamic status was compromised, so they could not cope with stress of post-op probable infection, and that's the other thing. The other thing was that hemodynamic effect was affecting tissue perfusion. So the post-op antibiotic was not quite effectively distributing in the tissue, so it was not doing what it's supposed to do. And what was the other thing? That's what I remember about post hoc analysis.
I think Reggie had a question for you.
So,
And this may not be for you guys, but directed towards you. It seems to me that a 300 milligram dose of a beta blocker on a beta blocker naive patient is
huge.
reckless. And I'm just wondering, how can someone get IRB approval for a study such as this where you are...
Some patients died.
That's another thing. I mean, how can the study... How can something like that happen or pass through IRB?
So it was 300 milligrams of IV metoprolol?
I guess it would be comparable...
It was PO.
100 milligrams up front, and then 12 hours later, 200.
200.
PO.
PO.
Up to 30 days after surgery.
Some people got IV if they couldn't take PO, but they adjusted the dose. But we don't,
But in our opinion, it was
too much.
Yes,
It was
it's
too
still
high of
high
a dose.
Yeah.
Too high of a dose for.
That followed with this, one of the principal criticizers of the study was Dennis Mangano, who's a name you've heard before. He was the guy that actually came up with the whole concept of, didn't come up with it, but strongly embraced the concept of treating people with people undergoing anesthesia with beta blockers. And you'll read Mangano's name everywhere. He's written everything there is to write on cardiac anesthesia. He's at the University of California, San Francisco, and has a cardiovascular research institute there. And he criticized the study on the basis that the dose of beta blocker used was too high. And you'll notice that there were no U.S. centers involved in this study, that these were doses that were used widely in Europe, but that they were considered to be much too high for doses that are used here in the United States. So it was criticized just on the dosage that was selected.
You asked us before about, Reggie, you mentioned about IRBs. We tried to find out how the approval was granted, and they had some kind of local review boards at those institutions, and everything was done with informed consent and legally signed. So we went through that.
It's an individual institution.
Yes, at an individual institution. There was no centralized body that approved that the research on that scale.
So
How many countries? 130 hospitals, I think it was, or something like that. And over the 5 years, something like that.
2002, 2000.
Yeah, 5 years.
There was also some speculation later on after the study that beta blockers may somehow rob the central nervous system of some sort of self kind of autoprotective, that it takes away that ability of the central nervous system to do that. But that's all speculative too. That beta blockers may have a constellation of side effects that haven't previously been described. So who knows? But I wanted you to hear about this because you'll hear about the POISE trial, and this is what it's all about.
So
Okay.
I think it's a perioperative ischemic evaluation. That what it says. You're right.
All right. Thank you.
Thank you. Thank you.